All right, good morning, everybody. Once again, thank you all for coming to the Department of Medicine's Grand Rounds. Particular thank you to those who have joined us in person. I think this is our best crowd all year, so thank you so much. It really makes a difference to see faces here in the crowd. I'll just give a brief introduction to our two speakers today. We have a special talk, and then we'll get the perspectives on these SGLT2 inhibitors from two divisions, from nephrology and cardiology. So on the cardiology side, we have Dr. Javaheri, who is a transplant heart failure cardiologist and also does a lot of basic science research in lipid metabolism, most recently having done a lot of work with SGLT2 inhibitors in various disease states from, of course, heart failure to COVID-19. Then on the nephrology side, we have Dr. Khoury, who's an expert in the metabolic effects of CKD and has a significant background in clinical nutrition and obesity medicine. So he will bring that perspective to the conversation. So without further ado, I will hand it over.
All right. Well, thanks everyone, and thanks for inviting us to this talk on SGLT2 inhibitors. So we'll try to give you a bit of evidence and on the mechanisms from a nephrology and a cardiology perspective. And these are our disclosures for starters. And for learning objectives, so this is obviously going to be interesting. It's two of us talking, cardiology versus nephrology. If you're expecting a fight today, like we're used to on wards, or hopefully not, this is not going to be the case. Ali and I were chatting about these Glomflocken tweets about nephrology versus cardiology all the time. So this is not going to be the case today. There's a lot of learning objectives. We'll hopefully try to get through them. And there's a lot about SGLT2 inhibitors we may not be able to cover. So we'll try to go over that in the end with questions. So first of all, sort of an interesting tidbit about history. SGLT2 inhibitors and fluorescein, one of the first sort of inhibitors of SGLT2 inhibitors, were first discovered from apple trees, apple tree bark specifically. And they weren't sort of identified to sort of work on the kidney and the tubules until later in the 80s. This gentleman here, Joseph von Mering, is probably more known for the role of the pancreas in producing insulin, but had done some work about fluorescein initially. And the interest in SGLT2 inhibitors sort of started off with the discovery of SGLT1, which is available in or present in the intestines and responsible for intestinal glucose transport. SGLT2s that were similar were later discovered in the tubule, only to later find out that SGLT1 as well is expressed a little bit at a lower extent in the tubules as well. And so overall, this history with fluorescein and the inhibition of SGLT inhibitors has been around for more than 150 years. But the advent of them into the clinics has sort of been progressing over the past 20 years or so, 15 years mostly, with the discovery of these sort of selective inhibitors of the SGLTs. And I'll leave you now with Ali to sort of go over a little bit more about how the SGLT2 inhibitors sort of studies first rolled in heart disease.
Thank you very much, Dr. Khoury. So it all started with basically the failure of certain diabetic drugs to improve cardiovascular outcomes. And in particular, experience with the glitazones led the FDA to basically come out and say, you need to prove that glucose-lowering drugs aren't harmful. So the big winner of that is basically this class of SGLT2 inhibitors. So this trial here, EMPA-REG, was designed actually as a non-inferiority trial to prove that these glucose-lowering agents didn't harm people in terms of the cardiovascular outcomes. And as it turned out, there was actually a mortality benefit in EMPA-REG in terms of all-cause mortality in diabetic patients, and an improvement in terms of both CKD and in terms of heart failure. And so that observation in EMPA-REG and other trials led to the thought by Mikhail Kosy-Borod and others that SGLT2 inhibitors may actually be beneficial in patients with heart failure, independent of diabetes status. And so now fast forward 7 years since the publication of EMPA-REG, and we have multiple trials in both patients with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. I'm not going to go through every trial, but I'm just going to show you this meta-analysis of DAPA-HF and EMPEROR reduced, so 2 trials of dapagliflozin and empagliflozin, and this is the hazard ratio overall for all-cause death and also cardiovascular death, both favoring SGLT2 inhibition in patients with heart failure and reduced ejection fraction. Now, you'll probably hear talks where people will say, the data support a bigger reduction in heart failure hospitalization compared to mortality, and that's true. No individual trial was actually powered to observe or was powered for all-cause mortality. So I think these meta-analyses are actually more telling than the individual trials in that regard. In addition to that, there appears to be a class effect in terms of improvement in quality of life with both dapagliflozin and empagliflozin in patients with heart failure and reduced ejection fraction. And because of the success of these trials in HFrEF and to a certain extent the lack of clarity in terms of a mechanism from glucose excretion in the kidney to improved heart failure survival and reduced hospitalization, the question became, okay, are these drugs also protective in patients with preserved ejection fraction? To put it another way, the diabetes studies saw a reduction in heart failure, but didn't really classify patients in terms of HFrEF and HFpEF, leading to the possibility that the drugs actually are protective in cardioprotective against hospitalization and mortality in patients with preserved as well as reduced ejection fraction. And the first study to really address this in a larger population is a study of a drug called sotagliflozin. This is the SOLOIST trial, and these investigators enrolled patients with diabetes at the end of their heart failure hospitalization. Once they were stable, randomized them to sotagliflozin or placebo. Sotagliflozin is interesting for a couple of reasons. One, it's not used in the United States, and two, it's often considered to be a less specific inhibitor of SGLT2, meaning that it has some activity also against SGLT1. But I don't really think that the benefit here is related to SGLT1 activity, in part because of some studies we've done in the lab recently. So that observation was sort of the first one, that there is benefit in patients with reduced and preserved ejection fraction. And since that time, there have been studies with both empagliflozin and dapagliflozin in the HFpEF population, consistently showing improved primary endpoint with SGLT2 inhibition, a reduced combined death and heart failure hospitalization. In the HFpEF population, this effect is mostly driven by the reduction in heart failure hospitalizations. Now, that's also led to a further controversy about whether the drugs are actually effective in HFpEF or not, or whether these studies were just cleverly designed. So this group also performed a pre-specified meta-analysis of patients in DAPA-HF and DELIVER. So these are patients who were randomized to dapagliflozin, who either had reduced in DAPA-HF or preserved ejection fraction in DELIVER. And the question here was, what are the overall outcomes? Do they support reductions in heart failure hospitalization? And were there interactions across the spectrum of ejection fraction in these patients? So I think the 2 points that are important here, number one, they're fairly consistent outcomes, reducing hospitalization with SGLT2 inhibition. And that effect in adjusted models is about a 25% reduction. And then there's about a 10% reduction in all-cause mortality in these meta-analyses. Are there interactions with left ventricular ejection fraction? So here, what we've plotted from this study is basically the hazard ratio and the 95% confidence interval in blue for each of these outcomes: CV death, all-cause death, hospitalization, and time to hospitalization. And on the x-axis is the left ventricular ejection fraction of the patient. So this is one of the most important slides in terms of, should we prescribe these patients to should we prescribe these drugs to patients with HFrEF and HFpEF? And I think from these data, the answer is yes, because the hazard ratios are pretty well preserved across the spectrum of LVEF, favoring treatment with, in this case, dapagliflozin. So just to transition a little bit back to, okay, these drugs are reducing hospitalization and the combined endpoint of hospitalization and mortality in these individual trials across the spectrum of human heart failure. What is happening at that time to the kidneys? Because in general, when you start heart failure patients on medical therapy, one big concern is their kidneys. And I think this study by Jeff Testani from Yale really exemplifies and elucidates some of the ways that I think about using these drugs. So in this study, Testani and his colleagues randomized patients to either monotherapy or combo loop diuretic empagliflozin. And I think the three things that are very cool about this study are that, first of all, there was a synergistic effect with loop diuretic and SGLT2 inhibition in terms of fractional excretion of sodium, number one. Number two, patients were acutely diuresed, obviously, and they exhibited reductions in both blood volume and plasma volume. But these effects on blood volume were much greater than the effects on plasma volume, which suggests that there could be more extracellular fluid loss, which is obviously something we strive for. And then the third thing is that there isn't a compensatory neurohormonal activation. So when you treat a patient with a loop diuretic, you get a compensatory increase in norepinephrine levels. But when you treat them with an SGLT2 inhibitor in the acute setting, you don't see that compensatory rise in norepinephrine. And actually, norepinephrine levels were reduced in patients who received the SGLT2 inhibitor compared to patients who didn't. So with that, I would just summarize some of the heart failure literature review section of the talk. SGLT2 inhibition reduces death and heart failure hospitalization in heart failure patients across the spectrum of ejection fractions. And it does that while having favorable renal effects. I will now turn it back over to Dr. Khoury.
All right. So the exciting thing about these drugs is that they're working on two diseases that are that intersect quite commonly in the clinics. Chronic kidney disease and heart failure patients are very commonly sort of intersected and may have sort of both diseases at the same time. And so these studies that we have so far have sort of been able to study patients at the cross-section of heart failure and chronic kidney disease, and obviously, excitingly for us, have progressively been shown to be as important in preventing chronic kidney disease and heart failure development separately. So getting back to this timeline, as Dr. Javaheri mentioned, sort of a lot of it started off with these initial trials with EMPA-REG that were not designed to sort of detect chronic kidney disease as an outcome, but the signal for that was detected early on along with the heart failure hospitalizations. And the studies that were more specific happened later on with Credence, DAPA-CKD, and EMPA-Kidney, leading right now to the FDA approval of dapagliflozin for chronic kidney disease, as well as others. So if we sort of take a renal or nephrology perspective of things, this is so the heat map of how we classify chronic kidney diseases. So over here, you've got your GFR stages. So going from stage 1 with a GFR greater than 90 all the way down to a GFR of less than 30. And on this side, you're seeing the progression of albuminuria from less than 30 to over 300. And the heat map sort of with the green showing low risk of progression or low risk of complications from a cardiovascular and renal outcome, and red being sort of the severe risk of complications from cardiovascular and renal outcomes. And so the initial trials, the CVOT trials, DECLARE-TIMI, CANVAS, and EMPA-REG, sort of captured a subset of chronic kidney disease patients with a mild level of CKD, both from an albuminuria standpoint and from a GFR standpoint. However, when researchers did subsequent analysis or sort of smaller analyses of the small number of patients, the few hundred, the dozens or hundreds of patients in each of these trials that had more advanced chronic kidney disease, they found a signal that SGLT2 inhibitors may have sort of retain that protection effect even at lower GFR levels. And the studies that we're most excited about that really show that at this point are Credence, which had a GFR of somewhere around the mid 40s to early 50s, DAPA-CKD that had a GFR averaging around 42 or so, and then most recently the EMPA-Kidney study that was published last week in the New England Journal that had an average GFR of around 35. And so if we look a little bit closer at those three studies, these are some of the largest studies that have been published in nephrology so far, with 4,000 to 6,000 patients on average being recruited, with an endpoint that is specifically sort of detected towards major adverse kidney outcomes, which is sort of a composite of worsening of GFR, development of hard outcomes for kidney disease, meaning going on dialysis or needing a kidney transplant, or dying from kidney diseases or cardiovascular disease. So Credence followed people for 2.5 years or so. Only 15% of those patients had heart disease. The GFR was around 56. Most of these patients had some significant albuminuria. And these patients sort of were most importantly maximally stabilized on renin-angiotensin blockade before they were enrolled in the study. Credence did not include any patients that were non-diabetic, and its hazard ratio for protection from major adverse kidney outcomes was 0.66, which was, to put it into perspective, sort of even better than what ACE inhibitors and ARBs have been shown to prevent kidney disease in diabetics. DAPA-CKD started off by including more kidney disease patients that are non-diabetic. However, there's only around 15% of those patients that have advanced chronic kidney disease or chronic kidney disease around stage 4. Most of these patients, 68%, were diabetic. Minority of them had heart failure, and again, the outcomes were fairly comparable with a hazard ratio of around 0.64. DAPA-CKD sort of, as I mentioned, included patients with chronic kidney disease, but it excluded patients with polycystic kidney disease, lupus nephritis, or ANCA vasculitis. And then this most recent study, EMPA-KIDNEY, that's honestly been sort of the most exciting based on its design, because it tried to capture patients with advanced kidney disease by trying to keep the GFR as low as possible, recruiting at least a third of the patients with a GFR less than 45, or having patients with chronic kidney disease at risk, which are GFR 45 to 90, so stage 3 kidney disease, but with risk albuminuria. Again, these patients were on RAS blockade. Glomerulonephritis patients were included as long as they were not actively on immunosuppression medications, but polycystic kidney disease patients were again excluded, and the hazard ratio is again consistently in the 0.72 to 0.6 range. So for the next sort of set of slides, what I'll try to go over is a meta-analysis of all the studies that we have. This is another recent study that got published last Sunday in the Lancet. And what this study is sort of a collaborative meta-analysis from all the trialists that have published so far, both in heart failure and chronic kidney disease with regards to SGLT2 inhibitors. And because all the trialists were involved, essentially what they were able to is adjust all the definitions, and most specifically the definition for major adverse kidney outcomes to maintain a GFR, a GFR less than 50%. Again, dialysis, kidney transplantation, or death from kidney or cardiovascular disease. And so what you'll see here is that, so if we just take a snapshot, these are the diabetic patients from all of these trials. The risk reduction is again around 40% risk reduction or more of reducing major adverse kidney outcomes. And what the trialists also did is essentially classify or order these studies in order of GFR, and then did an analysis to show that regardless of the GFR in all of these studies, the protective effect of SGLT2 inhibitors on the progression of kidney disease is still there. If you look at patients that were non-diabetic in those studies, which is a large number of patients when you group them up completely, sort of around 14,000 total, 7,000 that have been on SGLT2 inhibitors. Again, the protective effect is there with a risk reduction around 0.69 and consistently there. So overall, essentially what the studies that we have so far is that in both diabetic and non-diabetic chronic kidney disease, SGLT2 inhibitors are preventing the progression of kidney disease. And to sort of put it in another perspective, if we were to treat 1,000 patients with SGLT2 inhibitors for 1 year, we would be able to prevent 11 patients from progressing into more advanced kidney disease, requiring dialysis or dying from kidney disease. Other analyses that have sort of been done in this study was sort of to look at whether or not albuminuria or the risk of progression as evidenced by albuminuria adjusts or differentiates that risk. And again, in diabetics or non-diabetic, regardless of the level of albuminuria, whether it's mild or non-existent to very severe, the protective effect of SGLT2 inhibitors persists. I'll note though that if you read the EMPA kidney study, they noted that essentially in patients that are non-diabetic, and with low level of albuminuria, the protective effect of empagliflozin was reduced. And that's probably because patients with non-diabetic kidney disease that are non-albuminuric have a very slow rate of progression in kidney disease, and as such may not have been captured in terms of the protective effects of SGLT2 inhibitors. So finally, this slide sort of goes after different types of chronic kidney diseases, whether it's ischemic hypertensive kidney disease, glomerular disease, or other sort of unclassified kidney diseases. In those studies, again, the protective effect of SGLT2 inhibitors is there. And so that gives us sort of the confidence to start being able to recommend and use these drugs even in non-diabetic kidney disease, regardless of the background. All right. So using these drugs in practice sort of has to come in with weighing the risks and benefits of these medications. One of the major sort of things to consider about any medications, especially medications that are being used for kidney disease and heart failure, is whether or not these medications are associated with an acute kidney injury. And the gist of it from this collaborative meta-analysis in the Lancet, and again, these are 90,000 patients across all the different randomized controlled trials. There is no acute kidney injury risk from SGLT2 inhibitors, whether they are diabetic or non-diabetic. In effect, actually, SGLT2 inhibitors are protective towards the risk of acute kidney injury in patients that have diabetes, advanced kidney disease, heart failure, so patients that are high risk of having acute kidney injuries. SGLT2, importantly, are not associated with hyperkalemia. Again, they are somewhat protective from having high-risk hyperkalemia or clinically risky hyperkalemia, so potassium greater than 6. So in the studies that had, this is not the most recent paper, but this is a meta-analysis from earlier this year from Circulation that looked at studies that had accounted for hyperkalemia. And again, there is a reduced risk with a hazard ratio of 0.84 from developing significant hyperkalemia. And if you look at the sort of the serum potassiums on average in patients across the follow-up period of time up until 200 weeks or so, there is a slow decline in potassium concentration. This is not to mean that these patients are at risk of hypokalemia. There were no hypokalemia incidences in patients on SGLT2 inhibitors, but possibly somewhat of a protective effect, especially in patients that may need, that are obviously in all of those studies, patients were on ACE inhibitors, but the protection from hyperkalemia was evident even when patients were on mineralocorticoid inhibitors, such as spironolactone or others. Urinary tract infections were sort of first noted as a potential risk factor for SGLT2 inhibitors because they are sort of causing glucosuria, especially in diabetes, and sort of may put patients at risk of UTI. The risk is very mild, sort of an 8% increase in the relative risk of urinary tract infections. Most importantly, these urinary tract infections are not serious septic urinary tract infections. So overall, SGLT2 inhibitors were not associated with severe urinary tract infections. There is a risk of mycotic genital infections. Again, while that risk is there, what we need to keep in mind is that the overall incidence or sort of the number of participants that have developed that is not it's not sort of limiting, and these mycotic genital infections were on the most part sort of treatable in an outpatient setting with antifungals or outpatient management. Initially, when the SGLT2 inhibitors were sort of rolled in, one of the major sort of concerns was ketoacidosis, and that to this point is still why SGLT2 inhibitors have not been are not indicated and should not be used in patients with type 1 diabetes that are at high risk of developing ketoacidosis, while SGLT2 inhibitors may increase, or there is a higher risk for developing ketoacidosis. Again, only 120 patients out of the 40,000 patients that were involved in those trials developed ketoacidosis. So the sort of the absolute amount of patients that are getting it is still very small, but that risk is there, and so we should have clinical sense in patients that are on these medications to rule that out as a potential complication if they're presenting. And sort of on the flip side, using these medications has not been associated with a severe risk of hypoglycemia, mainly because their effect on A1Cs is fairly minimal. They are, as Dr. Javaheri mentioned, sort of weaker anti-diabetic medications. Their A1C effect is around the 0.2 range. And the concern about lower limb amputations started off mostly with the Canvas trial that showed sort of a marked increase in lower limb amputations in the population of patients they recruited. Beyond Canvas, the lower limb amputations have not been replicated, or the risk of lower limb amputations has not been replicated. And so a lot of this slight increase in the lower limb amputations that you see in diabetic patients here is driven by the Canvas trial. And there's a lot of heterogeneity in this meta-analysis when looking at these patients for that reason. Of note, though, patients that are non-diabetic have not been shown to have increased risk in lower limb amputations. And a lot of these complications are tending to happen more in diabetics, and more specifically diabetics that are not well controlled or are having risk of complications from the get-go. And then finally, in terms of complications, no risk factors for bone fractures. Again, this was a signal that was picked up earlier on in some of the studies and maybe Canvas, but that risk is very minimal and is not considered clinically important. So moving on, I think so far what I've hopefully we both presented is that SGLT2 inhibitors have a lot of evidence in terms of their clinical use, both for prevention of heart failure disease complications and chronic kidney disease complications. Excitingly for us nephrologists, they are, again, some of the bigger trials that have shown heart outcomes, preventing heart outcomes for kidney disease, meaning less progression to advanced stages of kidney disease, less development of end-stage kidney disease, and less death from kidney disease. And with EMPA-Kidney most recently, we know that they're usable even in advanced stages, stage 4. The mechanisms of SGLT2 inhibitors is a lot of where things are exciting for both of us nephrologists and cardiologists. So again, SGLT2 inhibitors are present in the proximal tubule. So they're located around here. And that's where around more than 90% of the glucose is reabsorbed by the kidney. And the main hypothesis of how the SGLT2 inhibitors work on the kidney was sort of posited to be related to the tubuloglomerular feedback. So again, to sort of remind us a little bit about from our medicine renal physiology courses, the tubuloglomerular feedback is this feedback in the kidney where the distal, where in the macula densa and the cells recognize or sort of detect a higher delivery of sodium chloride, and that releases adenosine. Adenosine will then act on the afferent arteriole, increasing the afferent arteriolar resistance. And by doing that, we decrease the pressure in the nephron and decrease the single nephron GFR. What we find as sort of, and that's where some of the studies of the fluoresceins and the SGLT2 inhibitors have shown, is that in diabetes, what happens, and in a lot of other sort of diseases with glomerular filtration, but diabetes mainly, there's sort of an upregulation of the SGLT2 inhibitors and increase in reabsorption of sodium in the proximal tubule. So that would lead to decreased delivery of sodium chloride to the macula densa, and as such, sort of an obliteration of this effect on the afferent arteriole. So the afferent arteriole dilates, and that increases the single nephron glomerular filtration and leads to this hyperfiltration in the kidney and an increase in glomerular pressure that has been associated with the glomerular sclerosis and the worsening of kidney disease. So SGLT2 inhibitors are then essentially decreasing that effect. They are acting on reducing the proximal reabsorption of sodium and possibly even blocking the sodium hydrogen exchanger in the proximal tubule. That increases the delivery of sodium again to the macula densa and will lead to a decrease in the single nephron GFR and decrease in the glomerular filtration. And that's sort of been posited as sort of one of the major effects of the kidneys on the kidneys by SGLT2 inhibitors. And this is sort of an interesting study that shows that sort of to our eyes. This is in vivo imaging of the afferent arteriole in rats after 30 minutes after they received a dose of empagliflozin. And this is the afferent arteriole before empagliflozin. And you can clearly see that 30 minutes afterwards, the afferent arteriole is vasoconstricted. And so with the SGLT2 inhibitors, we can sort of have a double hit on the glomerular hyperfiltration, with SGLT2 inhibitors leading to vasoconstriction on the afferent arteriole, and the ACE inhibitors and ARBs sort of working on the efferent arteriole so that we can collaboratively sort of reduce the glomerular filtration in the kidney. And that effect has sort of been thought to be responsible for this initial dip in the GFR that you see after you start patients on SGLT2 inhibitors. And honestly, we were lucky that sort of the initial trialists that were studying SGLT2 inhibitors did not panic and discontinue or sort of halt the studies when they first saw these initial drops in eGFR related to the SGLT2 inhibitors. As these drugs sort of work on decreasing the single nephron GFR and decreasing the glomerular hyperfiltration, they will lead to a reduction or in GFR. This is a reversible reduction, meaning if you were to stop the SGLT2 inhibitors at any time, the GFR will go back. But maintaining SGLT2 inhibitors will lead to slower progression in the GFR. So over here in blue, you'll see how the GFR evolves over a period of 24 months in these 30,000 patients that were getting SGLT2 inhibitors in real life. So this is not a randomized controlled trial, but sort of a real life analysis of patients on SGLT2 inhibitors. And so you'll see sort of a sort of progressive progression in the GFR over a period of 24 months. While comparatively, the rate of decline in patients that have been on SGLT2 inhibitors sort of slows down and is actually picking up after this initial dip that is related to the hemodynamic effects of the SGLT2 inhibitors on the kidneys. All right. This initial dip in GFR has sort of been sort of posited as an interesting thing, and some researchers, including Dr. McGill and Ziad Al-Ali from WashU, have looked at whether that dip in GFR is associated with the cardiovascular outcomes and the kidney outcomes. And it seems that at least regardless of the amount of dipping, whether they're dipping 10% or 30% in their GFR in the initial month that they're on SGLT2 inhibitors, that risk is not associated with the cardiovascular protective effect or the kidney protective effect that the SGLT2 inhibitors have. So while the SGLT2 inhibitors have these hemodynamic effects, and we think that at least in big part, the reason they're protective to the kidneys is related to their effect on glomerular hyperfiltration and interglomerular hypertension, we still have a lot of unanswered questions of how the SGLT2 inhibitors work on the kidney, but also how they're providing these protective effects on the heart. There's a lot of work and studies going around and a lot of hypotheses of what may be working. Obviously, they have some general hemodynamic effects in reducing high blood pressure, reducing glycemia in patients that are diabetics, but that doesn't explain the protective effect in non-diabetics. There may be some effect on the sodium hydrogen exchangers, and both in the heart and the kidney. Some signals have sort of detected that they have sort of an anti-fibrotic effect in the kidney, and there's a lot of interest in about how they affect the metabolism in the kidney and in the body overall, and sort of mimicking these fasting states that that have been shown to be protective in a lot of disease. And I'll let Ali sort of continue giving us sort of more perspectives on how the SGLT2 inhibitors may be working.
Thank you very much, Dr. Khoury. So just to summarize a little bit of this, what we've presented so far is clinical beneficial effects in patients with heart failure, diabetes, and chronic kidney disease, and some of the classic physiologic ideas, trying to explain how these drugs might work. And I think what Dr. Khoury nicely summarized is that those physiologic mechanisms are really insufficient to explain some of the beneficial effects that we're seeing. So I'm going to now kind of turn the leaf a little bit and tell you about some of the nice mechanistic studies highlighting work from Dr. Ben Humphrey's lab. Thanks in advance to Dr. Humphreys for providing these slides, recently published in Cell Metabolism, where they really took a deep dive into trying to identify the kidney protective mechanism. And so what Dr. Humphreys and his lab did is they designed a mouse model of diabetic kidney disease, which basically utilized a genetically diabetic mouse that was uninophrectomized and then treated with a virus to overexpress renin. So it's a little complicated. I hope I got all of it. But suffice to say that in these diabetic uninophrectomized renin overexpressing mice, there's an increase in creatinine, blood pressure, and blood glucose. And the yellow and the blue are the ones that received the virus, causing the renin overexpression, and now at 2 days and 2 weeks. And I'm just going to highlight how much work this was. So these are the first authors of the paper. They treated these mice with PBS, ACE inhibitors, rosiglitazone, ACE inhibitors and rosiglitazone, SGLT2 inhibitors, and the combination of ACE inhibitors and SGLT2 inhibitors, and then performed single cellular RNA sequencing on the kidneys from all of these mice. And I won't go through all of this, but basically what this type of analysis allows you to do is to identify the transcriptomic landscape. So the various individual cells, RNA expression profile, that allows you to identify the cells based on that profile into different populations of cells. Altogether, you can see this was a tremendous amount of work, lots of cells, lots of groups, lots of mice. And then in the analysis, they were able to take advantage of the fact, something we mentioned earlier, that SGLT2 expression is mostly in the S1 segment, so the more proximal segment of the convoluted tubule. Whereas in the more distal segment, there's much less SGLT2 expression. And then this data here just basically shows that they were able to confirm that in these two different subpopulations of proximal tubular cells. And that allowed the analysis to look at pathways that were differentially affected in the cells that express SGLT2 versus the ones that don't. The logic here is that the direct effects of the drugs would be evident in the cells that actually express the drug target. Whereas in the more distal cells that don't express the drug target, you'd be seeing more of the systemic effects. So now what I'm going to show you is the pathways that they identified at the top in the SGLT2 positive cells that were either downregulated or upregulated versus the SGLT2 negative cells. And the red dots are sort of the p-value threshold. So the upregulated pathways were response to starvation, response to hypoxia, and amino acid homeostasis. And so that did not reach significance in the SGLT2 negative cells, which basically suggests that while some of the effect might be the systemic effect leading to the starvation response, there's likely a much larger effect that's actually due to direct SGLT2 inhibition in the proximal cells that actually express SGLT2. So a little convoluted explanation, but basically what they were then able to do is identify a specific set of transcripts in these cells that do express SGLT2. These transcripts are involved in alternate splicing of RNAs, and then they were able to go on and do some elegant in vitro studies to show that those particular targets are involved in inflammatory responses in proximal tubular cells. So I think this is a really, really cool study and a really elegant use of single cell RNA sequencing to identify putative drug mechanisms. And thanks to Dr. Humphreys for sharing these slides. I really encourage you guys all to read this paper in Cell Metabolism from just a couple months ago. So I think that basically one idea is that SGLT2 inhibitors are protecting the kidney by upregulating pathways involved in starvation, fasting, hypoxia, and that turns on protective pathways in those cells, such as autophagy and anti-inflammatory pathways through this SR protein mechanism. But it still leaves the open question of how do you get from affecting the proximal tubule to these also systemic effects? And that's something that my lab was very interested in, is how do we essentially get to the systemic beneficial effects? And to study this sort of early in the pandemic, and also motivated by some interest in using these drugs in infectious diseases like COVID-19, we set up an experiment where we took obese mice with diet-induced obesity and impaired glucose tolerance. We gavaged the mice with dapagliflozin or placebo for 4 days, and then treated them with endotoxin, and performed a number of physiologic studies the next day to basically examine not only the phenotypes of the mice, but to try to sort of understand the physiologic mechanisms. I think what we saw in terms of the cardiac function was pretty interesting. So first, at the top, I'm showing you on your left echo images of mice that were either treated with saline or, and I'm sorry, this got cut off a little bit, but this is the control group. And this group here is the group that got endotoxin. And I think what you can appreciate is that the heart is much smaller, underfilled, and has a reduced ejection fraction. Now, on the bottom left, you can see dapagliflozin with saline, and compared to the just saline treated control heart, this heart is also a bit smaller, which indicates probably the acute diuretic effect leading to reduced end diastolic volume in just a couple of days. But the pumping function, the ejection fraction is well preserved. And then what happens here is very interesting. When you administer endotoxin to these mice, the size of the heart is unchanged. So the effect of endotoxin resulting in underfilling and reduction in ejection fraction basically doesn't occur, even though you're administering a drug that's an acute diuretic. And so when we first saw these data, we thought, okay, well, how could that possibly be that you're administering an acute diuretic drug, but preserving vascular volume in the setting of an inflammatory stress? And so we reasoned that what was happening was that dapagliflozin was preserving endothelial integrity. And so to assay this, we collaborated with Dr. Jae-Hong Cho in hematology, and now we utilized a mouse model where neutrophils are fluorescent, based on a fluorescent reporter, and these mice were then injected with fitzy-dextran, which is fluorescent green. The mostly neutrophils now are pseudo-colored blue. And what you can appreciate in this intravital microscopy from cremaster venules is that there's vascular leak, because you can sort of see at these branch points that there's this fuzziness, and that the pseudo-colored blue fluorescent neutrophils are interacting with the vessel wall. They're even transmigrating, and there's a lot of them. And when these now otherwise normal mice, meaning non-diabetic, non-obese, sorry, were treated with dapagliflozin, it's much crisper, there's less vascular leak, and there's fewer neutrophils now interacting with the vessel wall. So Dr. Cho's lab quantified the extravascular fluorescent green signal, and that is reduced by dapagliflozin. So I won't go through all the data, but basically the question is, what does this have to do with the kidneys? And so it turns out that in these animals, endotoxin treatment reduces the expression of a key receptor in the proximal tubule that's important for reabsorption of albumin and proteins that are involved in endothelial integrity. And when we treat these animals with dapagliflozin, that receptor, expression of that receptor is now preserved. So to sort of summarize, all of these basic studies, what we think is happening is that treatment with SGLT2 inhibitors basically protects the cells in the proximal tubule. And I think Dr. Humphrey's studies really nicely highlight what those mechanisms might be of the direct protection of those proximal tubular cells. And then that leads to basically obviously preserved function of those cells. If the cells are surviving better, if they're less inflamed, they can provide their normal functions. And one of their normal functions is actually to is that they're involved in reabsorption of critical proteins like albumin and this other apolipoprotein that my lab studies that's critical. It's called apolipoprotein M, and it's critical for maintenance of vascular integrity as well as anti-inflammatory effects and along the endothelium. And so we're really excited about these overall mechanisms, but I think what they highlight is that what I used to think in medical school is wrong, that you have your patient who gets sick and then they develop a kidney injury. I think what these studies are suggesting is that the kidney injury, in some cases at least, might actually be upstream and involved in the pathophysiology of the subsequent vascular leak and bad things that happen to a lot of our patients. So with that, I'll turn it back over to Dr. Khoury.
I think hopefully what we've both shown so far is that there's a lot of evidence to implement and start using these SGLT2 inhibitors in both chronic kidney disease and heart failure. We know that they are protective for heart failure and kidney disease in diabetics with cardiovascular disease risks, in diabetics with heart failure, whether it's preserved or reduced, in patients that have chronic kidney disease without diabetes or with diabetes, in early stages of kidney disease and more advanced stages of kidney disease, meaning stage 4 and beyond. What a lot of questions still remain about how the SGLT2 inhibitors are working. We don't know yet whether or not they're going to be useful in patients that are requiring immunosuppression, meaning glomerulonephritis patients, patients that are post-MI, that are pre-diabetic, that are kidney transplant recipients, or patients with fatty liver disease. But the prospects are definitely great. But for now, essentially what we feel is that now is the time to start using these drugs in the clinic while sort of being cognizant of sort of how to use them. And sort of we sort of put up a flow diagram of what we sort of perceive may be a reasonable way to start using these patients in clinic. And so if you're considering a patient to cardioprotect a patient from and to renal protect a patient with SGLT2 inhibitors, you can select patients down to a GFR of 20, not because we are concerned about SGLT2 inhibitors and GFRs less than 20. Again, in all the trials that have been done so far, the SGLT2s were continued even at GFRs below 20, but in the absence of evidence so far, the cutoff is 20 and above. Type 1 diabetics don't have evidence for the use of SGLT2 inhibitors yet, and patients with diabetic ketoacidosis should be excluded or sort of not sort of considered for SGLT2 use at this time. Polycystic kidney disease, patients on immunosuppression in the past 3 to 6 months, or patients that are at high risk of UTIs, may be not the most optimal candidates for SGLT2 inhibition. But otherwise, optimize the ACE inhibition and ARB use in these patients. If they're diabetic, monitor their A1Cs. If their A1Cs are above 10, this is the time to coordinate with endocrinology and their primary care doctors to optimize their glycemic control and maybe reconsider them for SGLT2 use. If they're non-diabetic, as long as if they have multiple risk factors, coordinate with the renal and cardiology team and initiate them on SGLT2 inhibitors with their collaboration. And then if they are on insulin and sulfonylureas once they're started, we can expect that there's around a 0.3 to 0.5% drop in A1C. That drop doesn't happen much if their GFR is less than 45, but if they're at risk of hypoglycemia, again, this is the time to coordinate. And in the patients that are at risk of sort of hypotension or hypovolemia are patients that have a systolic blood pressure that's already very low, or are on multiple diuretics. And in that situation, you may consider a drop by around 25%, but won't do that off the bat. Again, we should expect a drop in GFR around 3 to 5 millimeters, and then the first few weeks. We should not stop SGLT2 inhibitors. There's a slow progression of chronic kidney disease. These drugs were continued all the way up to dialysis or transplantation in all these clinical trials, and that should be how we clinically use them. If you see sort of a worsening of kidney disease more than expected, then this is the time to reach back to the cardiology and the nephrology team about that. And obviously monitor side effects, urinary tract infections, maintain sort of vascular health in these patients, and avoid episodes or consider holding these medications if they're dehydrated, infected, to limit the euglycemic decay risk. And with that, I think we'll leave it both to our acknowledgements.
So thank you, everyone. Obviously, like to acknowledge people in my lab. Dr. Ripoll was the one who spearheaded the sort of studies I showed at the end, along with Dr. Guo. Ken Amiyata is a nephrologist at SLU who's been working with us. Ahmed Diab, Mwala Ojan are postdocs in my laboratory. And also Daniel Huang is a resident part of the C-STAR program. I think she's been doing a great job recently working on these studies. And then importantly, Dr. Humphreys, Dr. McGill, Mikhail Kosiborod, who's been a great collaborator, and also with our movement into COVID-19 with SGLT2 inhibitors. So.
Yeah. And I'd also like to thank Dr. Humphreys for his support in our division, and everybody in the Division of Nephrology that have been great colleagues to work with. The Humphreys Lab, Haojia Wu, Parker Wilson, and Andrew Malone for their work on single-cell RNA-seq. And I'll put a plug in for the Diabetic Kidney Disease Collaborative. That's an American Society of Nephrology sort of effort that I've been a part of. So for medicine residents, this is a website that sort of goes through how we should manage diabetic kidney disease collaboratively in the clinics using endocrinology, primary care doctors, nephrologists, and cardiologists to sort of maximize our protective effects on these patients. And with that, we both like to thank you.
Thank you both so much. It was really terrific and wonderful tag team. I think we have a little time for questions. Leslie?
Yes, that was a great presentation. Thank you so much. I'm really intrigued by the effects of the SGLT2 inhibitors on endothelial cells. There's really, really nice work that you showed. And in that context, it was LPS, kind of more of a septic model. I'm wondering, you know, with either CKD or heart failure or hypoxia is such a big problem, do you think it's also preventing that endothelial leak, or what do you think the role of SGLT2 inhibitors on endothelial function is in those products?
Yeah, that's a really good question. I mean, I think that obviously we need to do those studies to be able to fully answer your question, and we're doing a lot of them. I think that I'm sorry, I don't know if they can hear me on. So the question was whether SGLT2 inhibitors may have an endothelial protective effect in the more chronic setting. And I think that in general, the answer is probably yes, but the mechanisms might be different, right? So obviously we use this endotoxin model where there's an acute vascular leak and reductions in albumin, as well as these circulating apolipoproteins that may not occur as dramatically in the chronic setting, but these effects on the inflammation in the proximal tubule are probably persistent, or they might be persistent. And then also, I think I would add that I am sort of biased that there is a fasting mimicry that does occur. So I wasn't trying to downplay that. I just don't think it's the central drug mechanism in the proximal tubular cells. And then there's a lot of effects related to that. So, you know, to answer your question, they're dirty drugs, and that may be a good thing.
Murali?
Great talk. Really appreciate that you guys went back and forth and share perspective. This is maybe for you, just, you showed the heart outcome benefits in heart failure population. Could should be front and center. Could you also just maybe summarize maybe some of the more patient-centered outcomes? And how do patients feel, especially if you have had with these drugs? But that's the biggest thing. A lot of them are older and it's just dramatic. And, how much benefit does it provide during exercise capacity, quality of life?
Yeah, I think, thank you very much. I only showed one slide on quality of life, and I think it's just challenging to exactly quantify. But one thing that Mikhail Kosiborod did is look at individuals that had what they defined as sort of a clinically meaningful change in the KCCQ, defined as like 5 points or more. And I think that the effect there was around, reclassification of like 15% of patients. So patients whose quality of life meaningfully deteriorated in the placebo group, about 15% of them were now reclassified into an improvement with dapagliflozin. I think that there's a big effect on hospitalization, and I think we don't maybe need a detailed study to tell us that patients hate being hospitalized. So I think that's another thing. In terms of the actual exercise capacity, there's a couple of mechanisms that might improve exercise capacity for patients. Obviously, reductions in right ventricular systolic, PASP, pulmonary systolic pressures, increases in hemoglobin. We didn't really touch on that, but that's another effect, off-target effect or direct effect of SGLT2 inhibition based on the kidney mechanisms. That might improve quality of life for patients and exercise capacity. But I don't think that that's something, the exercise capacity component isn't something that I've consistently observed across all trials for whatever reason, in part probably because it's hard to assess. Just 6-minute walk is very variable, as you know. And there are mechanistic trials that are ongoing to sort of dive deeper into that right now.
Sorry, very nicely presented. It's striking that the benefits are independent of GFR. So what is known about the effects of these drugs on aging and lifespan?
Yeah, that's a very good question. I've looked for that, and I mean that's something that you and I would be interested in based on some of our interest in fasting and whatnot. And it makes a lot of sense to examine that, especially because of the interest that has existed for metformin in that sphere. So I don't know that there have been any lifespan studies. I don't know if anybody else knows. No, not in models.
Chandra?
I have two questions. The first one is the cost of the patient.
Yeah.
Do you have some estimate on that? And then allergic response. I'm not talking about the side effects.
You want to take this?
What's the incidence? And how did you get anaphylaxis? What happens?
Yeah, I don't think anaphylaxis has been sort of a common adverse effect in the clinical trials that have been done so far. You're right, cost has been an issue. I will positively say that it's becoming less of an issue. Medicare coverage and Medicare Advantage coverage is becoming better. The copay for Medicare patients is probably around $30 a month or $40 a month until they hit their donut hole. So yesterday in clinic, one of the patients had to stop it for cardiovascular and kidney protection effects. But essentially, if you see them in clinic, don't remove it from their medications when they hit January. It's going to be refilled again, and hopefully we maintain some protective effect even with sort of limited use until the FDA and the insurance companies are becoming more compliant. But it's definitely a lot better and a lot need for prior authorizations compared to even a couple of years ago.
Thank you both very much.